Have you ever found yourself, wading through health info online, trying to figure out cholesterol, triglycerides,
hmm
all that stuff, and just wishing someone could break down what really matters? It feels like you almost need a medical degree sometimes just to understand your own health. Well, that's exactly why we're doing this today. Welcome to the deep dive. We're aiming to cut through all that complexity and give you a really clear picture of lipid disorders, what they are, how they might show up in, well, surprising ways, the debates around screening, and the treatments available. Our mission for you today is basically to pull out the most important nuggets from, a whole stack of sources, articles, research, or notes so you feel properly informed fast. So let's unpack this. When we talk about lipid disorders, what exactly are we diving into today, and why should it really be on our radar?
Right. So, at its core, lipid disorders or dyslipidemia, the medical term just means unhealthy levels of fats, lipids in your blood. Pretty simple concept, really. We'll mainly focus on two big ones today.
Hmm.
Hypercholesterolemia, that's high cholesterol, and hypertriglyceridemia, which is high triglycerides.
Okay.
And these aren't usually random. They often have specific underlying causes. For high cholesterol, you might see links to things like hypothyroidism, pregnancy, or even kidney failure. And
Interesting.
for high triglycerides, common culprits are things like diabetes, especially uncontrolled heavy alcohol use, obesity, steroids, sometimes estrogen therapy.
It's kind of striking, though. You mentioned most people don't even have symptoms, right? They're asymptomatic. So you could be walking around with these issues and have absolutely no clue. But if they are so silent, what are some of those maybe more unusual signs, the surprising things that might eventually hint that something's wrong?
Yeah, that's a really critical point, how silent they usually are. Many people feel perfectly fine,
Yeah.
but there are a few distinct signs that can pop up. Pancreatitis, for instance.
Ah, inflammation of the pancreas.
Exactly. And that can be really serious. It's particularly linked to sky-high triglyceride levels. Then you might see things called xanthomas. These are like uh, fatty deposits, yellowish lumps.
Where do those show up?
Could be places like your Achilles tendon, or there's xanthelasma. Those are lipid plaques right on the eyelids,
Right.
soft yellowish patches.
Wow, on the eyelids. So it's really sobering. These conditions can be totally hidden. And then maybe just a small plaque on your eyelids signals a much deeper issue.
Yeah.
Yeah, it really makes you think about proactive health, which brings up a really important question. If it's often hidden, how do we actually find it? Who should get screened? And, when? At what age?
Right. And this is where things get, well, interesting and a bit controversial. There isn't one single answer everyone agree on. Screening recommendations are generally based on your individual risk. Factors like your sex, your age, and cardiac risk factors.
Like smoking, high blood pressure.
It's exactly smoking, hypertension, and also family history of early coronary heart disease. Specifically, if a close male relative had it before 55 or a female relative before 65.
Okay.
Now, if you look at the big organizations, their guidelines differ slightly. The American College of Cardiology and American Heart Association, the ACHA, back in 2019, they said for adults 20 to 79 without known heart disease, it's reasonable to check risk factors every, say, 4 to 6 years. That helps calculate your 10-year risk of cardiovascular disease, or CVD.
Okay. Reasonable. What about others?
Well, the U.S. Preventive Services Task Force, the USPSTF, they have stronger recommendations. They say routine screening for men aged 35 plus and women 45 plus, especially if they're already at higher risk for coronary heart disease.
So there's definitely some debate there about the exact starting age.
Yes, considerable controversy, you could say.
Yeah.
But generally, the approach is risk-based. If you're considered higher risk, maybe you smoke, have high blood pressure, that family history we mentioned, maybe diabetes screening might start earlier. For men, perhaps 20-25, women maybe 30-35.
And for lower risk folks,
For lower risk individuals, it's usually later. Males typically around 35, females around 45.
it's fascinating how it's really not a one-size-fits-all thing. It depends so much on your specific situation. So let's say you do get screened, you get your results back, especially that LDL cholesterol number. What does that mean for your 10-year CVD risk? And crucially, what happens next? What actions might follow?
Precisely. That estimated 10-year risk becomes a key guide, especially here LDL cholesterol is between 100 and just under 190 milli-GDL. If you land in the very high-risk group, that's a 20% or greater chance of a CVD event in the next 10 years, then high-dose statin therapy is usually initiated. Pretty straightforward.
Okay. And if the risk is lower?
If you're high risk, that's defined as between 7.5 and 19% 10-year risk, particularly if you're aged 40 to 75, then a moderate intensity statin is often the starting point.
Right.
Now, for the intermediate risk group, 5 to 7.4% risk. It's more of a conversation. Shared decision-making between you and your doctor. A statin might be suggested, especially if your LDL is on the higher side, maybe over 160 mg/dL, or if you have other risk enhancers.
And the lowest risk group?
Low risk, under 5%. Usually the focus is more on lifestyle, maybe repeating the screening down the road. Statin therapy isn't typically indicated there.
Got it. That makes sense.
And it's important to mention a few other situations where screening and treatment are definitely recommended, sort of regardless of that calculated risk. Anyone 21 or older with an LDL persistently 190 mg/dL or higher, that's very high.
Okay.
Also, any patient who already has diagnosed clinical atherosclerotic cardiovascular disease, like a past heart attack or stroke,
Yeah.
and kids or teens under 19 who have familial hypercholesterolemia, that genetic form of very high cholesterol.
Okay, so now we know who might need treatment and why. Let's get into the treatments themselves. This is the exciting part, maybe, what we can actually do. And when we talk treatment, statins almost always come up first. They seem like the real workhorses here. Why are they so foundational?
They really are. Statins, or HMG-CoA reductase inhibitors, are so effective because they target the liver's cholesterol production line directly. They block a key enzyme, HMG-CoA reductase, which is basically the rate-limiting step in making cholesterol.
The main control switch?
Exactly. So by blocking that, the liver makes less cholesterol. And then it compensates by putting out more LDL receptors on its surface. These receptors grab LDL cholesterol, the bad kind, from the blood and pull it into the liver, clearing it out.
Ah, so it's a double whammy. Less production and more cleanup.
Mm-hmm.
Clever? Beyond just bringing the LDL number down, what are the main effects? How do they actually protect the heart?
Right. It's much more than just the numbers, though they do that very well, lowering total cholesterol, LDL, ApoB, even triglycerides by maybe 20–40%. They also give a modest boost to HDL, the good cholesterol, maybe 5%. But the cardiovascular protection is key. They help stabilize plaques in the arteries, making them less likely to break open and cause a heart attack or stroke.
Okay, stabilizing plaques. What else?
They also have significant anti-inflammatory effects. They reduce markers like C-reactive protein or CRP and dial down certain inflammatory signals like TNF-alpha, IL-6, IL-8.
Wow.
This inflammation plays a big role in atherosclerosis, so calming it down is really beneficial. And interestingly, some evidence suggests they might even help prevent bone loss.
That is fascinating. Such broad effects from a cholesterol drug. It really shows how interconnected things are, doesn't it? But naturally, no medication is perfect. What are the main side effects or considerations people need to be aware of with statins?
Good question. The most talked about side effect involves muscles. Myalgia, which is muscle aches or soreness, can happen in up to 10% of people. Less commonly, you can get myositis, which is actual muscle inflammation with elevated muscle enzymes. And rarely, very rarely, rhabdomyolysis, severe muscle breakdown.
Is that risk higher with certain combinations?
Yes, the risk of muscle problems, especially rhabdomyolysis, goes up if statins are combined with other drugs like fibrates or niacin. It's worth noting if someone has had muscle issues, rosuvastatin and pravastatin are often considered safer options once things settle down.
Okay. What about the liver?
Liver effects or hepatotoxicity can occur. Mild increases in liver function tests, LFTs, are fairly common and usually not a big deal. But if those LFTs go up significantly, say 3 times the upper limit of normal, then the dose might need reducing or you might switch meds.
Gotcha. Any other common ones?
GI symptoms, nausea, indigestion can happen. Kidney function needs consideration. Though atorvastatin is often okay even in severe kidney dysfunction without dose changes. There's also a small but documented increased risk of developing type 2 diabetes. Statins seem to inhibit something called GLUT1, which helps cells take up glucose.
Right.
And a really crucial point, statins are contraindicated in pregnancy. They absolutely should be stopped before trying to conceive and are generally discouraged during breastfeeding.
Okay, definitely noted on the pregnancy front. So statins are the cornerstone. But what else is in the toolkit? Let's move beyond statins. What about, say, Izatib?
Izatib works differently. It targets cholesterol absorption in your gut. It blocks a specific transporter in the small intestine, so less dietary and biliary cholesterol gets absorbed into your system and reaches the liver. This prompts the liver, again, to increase LDL receptors to pull more cholesterol from the blood.
So it complements statins.
Exactly. It's often used with a statin for added LDL lowering. On its own, it lowers LDL by about 20%. Side effects are usually things like headache, maybe some GI upset, diarrhea. Rare liver issues are possible, potentially more so when combined with statins. And importantly, you generally avoid taking it with bile acid sequestrants because they can bind it up.
Okay. And speaking of bile acid sequestrants,
Well,
what are those? Names like cholestyramine.
yes, cholestyramine, cholestyramine, cholecivellum. These are interesting. Think of them as large resin molecules, almost like sponges, that stay in your intestine. They aren't absorbed systemically. They work by binding to bile acids in the gut. Bile acids are made from cholesterol in the liver. By binding them up, the resins prevent them from being reabsorbed, so they get excreted in your stool.
And the liver has to make more.
Precisely. To make new bile acids, the liver pulls cholesterol from the blood, increasing its LDL receptors and lowering your serum LDL. Because they aren't absorbed, they're considered quite safe, actually the safest lipid drugs for use during pregnancy.
That's good to know.
Cholestyramine has even been shown to reduce cardiovascular mortality.
What about downsides? Those sound pretty good.
The main downsides are GI-related. Constipation, nausea, bloating are pretty common. Also, because they bind things up, they can interfere with the absorption of fat-soluble vitamins A, D, E, and K,
Ah, okay.
and also other medications like warfarin or some antibiotics. So you have to time your other meds carefully, usually take them an hour before or maybe 3 to 4 hours after the resin. They can also potentially affect liver enzymes or, by interfering with vitamin K, affect blood clotting time, your PTINR.
So careful monitoring needed there.
Definitely. And they're generally avoided if you have very high triglycerides or complete biliary obstruction.
Got it. Okay, next up. Nicotinic acid or niacin? Vitamin B3. What's its angle?
Niacin has a few mechanisms. Works in fat tissue to reduce the release of fatty acids, which lowers triglyceride production. It reduces LDL formation. But its most unique effect, really, is that it's the most effective drug we have for increasing HDLC, the good cholesterol.
How does it do that?
It seems to decrease the liver's uptake or breakdown of HDL so it sticks around longer. It also helps clear out ApoB-containing lipoproteins.
That's fascinating, actively boosting the good stuff. But niacin, it's kind of infamous for a particular side effect, isn't it?
Ah, yes. You're thinking of the niacin flush.
That's the one.
It's very common. Intense flushing, feeling warm, itching, sometimes headache, often worse with hot drinks or alcohol. It happens because niacin triggers the release of prostaglandins in the skin.
Can you do anything about it? It sounds pretty unpleasant.
Yes, thankfully.
Yeah.
Taking a low-dose aspirin or an NSAID about 30 minutes beforehand can help significantly block the prostaglandin effect. Also, starting with a very low dose and increasing slowly and taking it after a meal helps. The good news is, most people develop tolerance to the flush within maybe a couple of weeks.
Okay, that's manageable then. Any other issues with niacin?
Yes. GI upset, nausea, vomiting, even peptic ulcers can be a risk again. Taking it with meals helps. Liver abnormalities, sometimes severe, can happen. It can also raise uric acid levels, potentially triggering gout, and raise blood sugar, so diabetics need careful monitoring. Hypotension, a risk of myopathy, especially with statins, arrhythmias, and rare eye issues like macular edema, are also possible.
So quite a few things to watch out for.
Definitely. And it's generally contraindicated in pregnancy, active ulcers, severe gout, or with concurrent statin use due to that myopathy risk.
All right. How about omega-3 fatty acids? Fish oil.
Right. Things like EPA and DHA and the prescription form icosapent ethyl. Their main action is reducing VLDL triglyceride production by the liver. The American Heart Association generally recommends eating fatty fish at least twice a week for heart health.
And the supplements or prescription forms.
They're mainly used as an add-on therapy for severe hypertriglyceridemia, like when triglycerides are really high, say over 500 or even 1,000 milli-GDL. Icosapent ethyl specifically has an indication, on top of statins, to reduce cardiovascular events in adults who still have triglycerides over 150 milli-GDL despite statin therapy.
Side effects, besides maybe tasting fishy.
Yes, the fishy burps are definitely a thing patients mention. Also, maybe some joint pain, nausea, indigestion. Interestingly, they can sometimes slightly increase LDL levels, and they might slightly prolong bleeding time, so caution is needed if you're already on anticoagulants.
Okay. Now let's talk about the newer kids on the block. PCSK9 inhibitors. Alirocumab, evolocumab. These sound different.
They're very different, quite revolutionary, actually. They're monoclonal antibodies engineered proteins. They work by targeting a protein called PCSK9. Normally, PCSK9 binds to LDL receptors on the liver and causes them to be broken down inside the liver cell.
So PCSK9 gets rid of the receptors that clear LDL.
Exactly. These inhibitors act like decoys. They bind to the free PCSK9 in the blood, preventing it from attaching to the LDL receptor. The result, the LDL receptor isn't targeted for degradation as much. It gets recycled back to the liver surface more effectively. This means the liver has more active LDL receptors available to pull LDL cholesterol out of the blood. It dramatically increases LDL clearance.
Here's where it gets really interesting. So this is a completely different mechanism than statins or ezetimibe. What are the big advantages? Why the excitement?
The main advantage is their sheer power in lowering LDL. They're the most effective agents we have for reducing LDL-C, often by 50–60% or even more, on top of statins. And this translates into significant reductions in cardiovascular risk, fewer heart attacks, strokes. Alirocumab has even shown a potential long-term mortality benefit after an acute coronary event.
So they're used with statins.
Yes, typically. They're indicated in addition to maximally tolerated statin therapy. Their mechanisms complement each other. They're used for patients with established cardiovascular disease to further lower risk, or for those with familial hypercholesterolemia who need more LDL reduction. And a really key advantage, they don't seem to significantly increase the risk of myopathies, those muscle problems, which is a big plus compared to combining other drugs sometimes.
That's a huge benefit. What about downsides?
They're injectable, which is one factor. The most common side effects are injection site reactions, redness, itching, swelling. It's small, less than 1%. Potential risk of neurocognitive effects noted in studies, though it's still being evaluated. And maybe a slightly increased risk of common infections like colds, UTIs, upper respiratory infections.
Okay, impressive stuff. Lastly, let's touch on fibrates. Gemfibrozil, fenofibrate, how do they fit in?
Fibrates work primarily on triglycerides, though they have some LDL effects too. They activate a receptor called PPAR-alpha. This increases the activity of lipoprotein lipase, an enzyme that breaks down triglyceride-rich particles. They also reduce the liver's production of VLDL, the main carrier of triglycerides.
So mostly for triglycerides.
Primarily, yes. Their LDL effect is modest, and sometimes they can paradoxically increase LDL, especially if triglycerides are very high to start with. They might be combined with other drugs, but cautiously.
Cautiously why? Side effects.
Yes. GI symptoms like nausea, diarrhea are common. They can increase the risk of cholesterol gallstones because they make bile more lithogenic. And the big one, a significantly increased risk of myopathy when used together with statins. That combination requires very careful consideration and monitoring.
Right, you mentioned that earlier with statins.
Exactly. And they're generally contraindicated if you have significant kidney or liver dysfunction, gallbladder disease, and also in children and during pregnancy.
Okay, that covers the main lipid drugs. Now, as we sort of zoom out to overall cardiovascular health, our sources also mention aspirin. It's not a lipid drug, obviously, but it's so important in this area. What's the quick take on aspirin's role here?
Aspirin is absolutely crucial, mainly for its antiplatelet effect. It stops platelets from clumping together and forming clots. So its key indications are in preventing clots in situations like acute coronary syndromes, heart attacks, after a heart attack or stroke or TIA, mini stroke. Also for pain, fever, and inflammation at higher doses, and specific conditions like rheumatic fever or Kawasaki disease.
But it has risks too, right? Especially stomach issues.
Definitely. GI upset, ulcers, and bleeding are common because it inhibits COX-1, which normally protects the stomach lining. It can also affect the kidneys, rarely cause asthma flares in sensitive people, and is linked to Reye syndrome in children with viral infections. That's why it's avoided in kids typically.
Okay.
Increased bleeding risk overall is a major factor. It can also affect uric acid excretion, so caution and gout, and interacts with other blood thinners like warfarin.
So who shouldn't take it?
People with active ulcers or significant kidney injury, certain bleeding disorders like hemophilia, maybe severe G6PD deficiency. In an overdose situation, acute toxicity can cause a range of problems. Neurological like fever, confusion, seizures, ringing in the ears, GI issues, lung problems, and characteristic changes in the body's acid-base balance.
And how is that managed?
Management is mainly supportive care, IV fluids. A key intervention is making the urine and blood more alkaline using IV sodium bicarbonate. This traps the aspirin molecule and helps the kidneys excrete it much faster. Activated charcoal if ingestion was recent, and sometimes dialysis in severe cases.
Wow. Okay, so what does this all mean? We've really gone deep today from, lipid disorders often being silent to the sometimes surprising signs like eyelid plaques, the debates around who needs screening and when, all the way through this incredible range of medications, statins, ezetimibe, PCSK9s, and the rest, their mechanisms, their benefits, and yeah, their potential downsides too. It's definitely not simple, is it? It's complex.
Not at all simple, no. But hopefully breaking it down helps. The key takeaway is really understanding your own individual risk. Knowing that screening guidelines vary and that treatment is tailored, involving conversations with your doctor. and recognizing that this is an area where medical science is constantly moving forward, offering more specific and powerful tools. Knowledge really is power here. Which kind of leads to a bigger thought, doesn't it? As we get better and better at targeting these complex conditions like dyslipidemia with such specific tools, how might this change our whole approach to preventive health in the future? Not just for individuals, but maybe for public health strategies more broadly.
That's a really powerful question to think about. How precision medicine might reshape prevention. Interesting. We really hope this deep dive has given you some valuable insights. Maybe think about what part resonated most or what sparked your curiosity further. Hopefully, you feel better equipped with this knowledge to continue your own health journey.